Next up, we have Dr. Jay Crosson, who's going to speak to us. Dr. Crosson is currently a senior lecturer at the Kaiser Permanente School of Medicine in Pasadena, California. We can't see the weather out there in California, but we hope that it's sunny, as it always is, and that you guys are hanging in there with the COVID-19 resurgence. Dr. Crosson is the immediate past chairman of MedPAC, the Congressional Medicare Payment Advisory Commission. In that capacity, he has been tasked with advising Congress on strategies to help improve the delivery of high-value, high-quality, coordinated care for Medicare beneficiaries, and really to preserve the fiscal integrity of the Medicare program and to optimize its value. So, Dr. Crosson, we're excited to hear your remarks. Thank you.
Again, thank you, Deborah, and Ted and Francis for inviting me. This is an important topic. Don, you built me up. I hope I can pass muster in terms of what I present here. What I've been asked to do by Francis and Ted is to focus a little bit on let me go to my, so I want to talk a little bit about the size of the problem here. I realized from looking at your prior meetings that you've gone over this a number of times, but I thought I'd do it anyway. And then Francis asked me to talk a little bit about the buy and bill payment process, which is used for administered drugs in the Medicare program, as well as outside of the program. And a little bit about the role of the intermediaries, group purchasing organizations and distributors, wholesalers. Those terms are used interchangeably often. And then I thought what I would do, and this is very much in keeping with Don's presentation, is talk a little bit about the proposed reform that we put together a few years ago at MedPAC of the Part B payment process, which includes the issue of the potential incentive to use more expensive drugs. And then I put together, and I'm not going to talk about them directly, but all of the information in my talk has come from, most of it anyway, has come from references, and those are all available in the last slides and are accessible via the internet. So this is from the MedPAC 2019 briefing book, which MedPAC books out every year. And it's a little difficult to read, I understand. But essentially, it looks at the spend of Part B drugs in Medicare over the past 12 years or so, 2005 to 2017. An increase from $13.4 billion in 2005 to $32 billion in 2017. What's interesting, if you look at the two lines below the total increase, is the fact that the use of Part B drugs by physicians independent of hospitals went from $9 billion to $18 billion, roughly doubling, and about a 7% year-over-year increase, whereas the use of Part B drugs in the hospital outpatient setting during that period of time went from $2.8 billion to $12.3 billion, almost fourfold increase, or 17% year over year. And this is reflective of what we've seen in the United States, which is, for various reasons, many of them economic, most of them economic, physicians, particularly those like oncologists who use Part B drugs in the Medicare program, have moved into the hospital setting or in some sort of relationship with hospitals such that they can bill the Medicare program in total at higher rates. And this is a problem that extends beyond drug usage. So I know from looking at your prior meetings that you've seen the top 10 drugs many times over, and they're probably slightly different every time you look at them. But I thought this was an interesting slide. This is, again, from the MedPAC staff, and looks at the top 10 Part B drugs. Most of these are anti-cancer drugs, and then there's a few others related to macular degeneration and rheumatoid arthritis, et cetera. The total expenditure there for those top drugs in 2017, again, was $13.64 billion of the $32 billion, or 43% of the total. So the top 10 drugs are nearly half of the total expenditure. What I thought was interesting, and I graphed it on to this MedPAC data, the last column, excuse me, which came from ASPE, the Assistant Secretary for Planning and Evaluation. And they did an estimate of the increased costs borne in the United States compared with, and it's a collection of roughly OECD countries, and you see those figures to the right-hand side of the slide. What that essentially means is that just for these 10 drugs, and if you add up all the derivatives here, in 2017, the U.S. spent $6.7 billion more than it would have spent had it been purchasing drugs on some other basis, in line with what other developed countries are able to do. So that's sort of the size of the problem. The next piece here is Francis asked me to talk a little bit about the buy and bill system. I will in detail, but I found this diagram, which I did not create, but I included it because I thought it was useful. What it depicts is the flow of both product, contractual relationships, and financial flows involving the manufacturers, the wholesalers, the providers themselves. In the case of CMS or insurance companies, because this graphic is not just a Medicare graphic, it's buy and bill for both Medicare and commercial. And it shows the relationships of product movement in blue, movement of money in the dotted green lines, and then the contract relationships in red. And this is, I think, I'm not going to go through all these lines. I would take up the rest of my talk. But I did think this might be useful to you to refer to. And again, in the references, you'll find where this was derived from. Just a couple of details here. There's one line that does not exist in the Medicare program. That's in the upper right. Rebates paid by the manufacturers to CMS. That does not occur. It occurs in the commercial world. And then in the very middle of the slide, you see in tiny little letters, GPO. I'm going to talk about that in a minute, group purchasing organizations. The slide does not talk about where the financing of that comes from, and I'll talk about that in a minute. So this is essentially how it works in the Medicare program. Physicians and hospitals through their outpatient services order purchase and administer drugs. These are usually derived from the wholesalers and distributors, and I'll talk about that in a minute. After the drug is administered to the beneficiary, then the provider, either the physician or the hospital, bills Medicare. As you discussed in one of your prior meetings, the physicians have to add now the JW code, which is a measure of waste. Medicare then reimburses the physicians at 80% of the volume-weighted average sales price plus 4.3%, which is 6% by law, but it's reduced because of sequester, and then an administration fee for the actual storing and injecting of the medication. Providers then collect coinsurance from the beneficiary, which is 20% by law. About 75 to 80% of beneficiaries have Medigap. Medigap pays for that, and it's usually cycled through the CMS payment, not always, but mostly. And for beneficiaries, about 34% of Medicare beneficiaries are in Medicare Advantage. The payment process is different and it's unique. Every Medicare Advantage plan contracts with providers for Part B. Sometimes the benefit, that is the number of drugs that are provided, is reduced. It varies. And in some cases, there's no copayment, and in other cases, there is. And as you've seen one Medicare Advantage plan, you've seen one. So in terms of these intermediaries, the first one to think about is the group purchasing organization. And that appeared again on the little diagram right in the middle, sort of there. The largest of these organizations you see here, Premier, Vizient, et cetera, their purpose is to aggregate provider purchasers in order to use volume to negotiate lower prices from the manufacturers. They get paid, oddly enough, by the manufacturers and distributors as a percentage of the prices charged. And there's an issue right in there you can see. By law or regulation, I'm not sure, it's 3% maximum that they can get. They don't take possession or title of the drugs. They're just an intermediary that uses their collective purchasing power to try to get lower prices for the distributors and then for the end users. And then there's the distributors and wholesalers. They use interchangeably these terms, AmerisourceBergen, Cardinal Health, et cetera. They actually play the role of consolidating the drug sourcing and storage so that manufacturers don't have to contract and deal with every single provider of Part B drugs in the Medicare program and outside of the Medicare program. They then store the drugs and provide them to the physicians and hospitals, and they provide, in addition, related supplies as requested from their customers. Their revenue sources, and this took some digging because if you haven't found it already, once you get into this this flow of dollars and contractual relationships, much of it is hidden on purpose. But essentially, they're paid by the manufacturers, and then there are certain fees that come from the providers, usually for providing additional services such as analytics. They do take possession and title to the drugs. I hope that's a little helpful in understanding the whole interstices of the flows of the contract relationship, the flows of product, and the flows of drugs as well, of money as well. I'm sorry. So what I'd like to do now, and I'm watching the time here, is to get back to the sort of larger approach that Don was talking about. I want to talk a little bit about how our commission that Deborah described to you tried to take on this larger issue a few years ago. So MedPAC, for those of you who are not aware, is a independent body established by Congress about 20-some years ago. It's independent. The members are appointed by the Government Accountability Office. We provide very specific recommendations annually to Congress in March about the payment rate updates to providers. In other words, hospitals should get paid X more or less next year than they got paid in the previous year. And that comes out in March. And then in June, specific policy recommendations about the structure of Medicare, its processes, issues of access to care, quality, costs, and other issues affecting the Medicare program. We have 7 public meetings a year, much like you're doing here, and information about MedPAC can be accessed by going on medpac.gov. All the reports are publicly available, as well as other information. So in our June 2017 report to the Congress, we tried to take on the issue of the cost of Part B drugs for many of the reasons that Don talked about. We found that the current buy and bill process was problematic for a number of reasons. There is the question about whether or not physicians in some specialties are influenced by the fact that they can get paid more if they use more expensive drugs. Interestingly, the data on that was somewhat lacking. But I think we ended up with the understanding that at very least, there's no counter incentive to adding to the drug cost problem in the current buy and bill process. In the end, we examined a model that CMS had tried some years ago called the Competitive Acquisition Program, or CAP model, and it did not work very well. And the primary reason it didn't work very well was that it wasn't effective. There were no. The idea was to insert an intermediary here. Dr. Watanabe, you asked in one of the previous meetings, why can't Part B be more like Part D? Well, that was an attempt to sort of do that by inserting a negotiating intermediary. The problem was that the intermediary had no power. It had no formulary power, et cetera, et cetera. And so there were no takers on this model, and it kind of disappeared. What we did was to pick this model up, and that was, again, sort of like, could we make Part B a little bit more like Part D? Because the Part D program has been successful in relative terms in reducing the cost of prescription drugs. And so we called on Congress in 2017 to establish something called the Voluntary Drug Value Program, or DVP. And here's what the DVP program would do. It would empower Medicare to contract with a small number of vendors. Now, those vendors could be group purchasing organizations, they could be Part D plans, they could be distributors, perhaps, or they could be large entities set up by a consortium of providers, new entities. But their role would be to negotiate directly with the manufacturers for providers, this is physicians and hospitals, who aligned with them. And so the idea would be there would be a small number of these vendors. This is not terribly different from how things work in Part D. But they would be negotiating armed with, behind them, a number of end users. They would be paid an administrative fee. They would not be paid based on the total cost or price. But they would also have the opportunity to increase their revenue based on savings accrued by the Medicare program. This is a Medicare proposal. It could be expanded beyond that, but at the moment, it's a Medicare proposal. And those savings, and there's an issue of how those would be calculated, obviously, they will also be potentially shared with the providers. So in this case, the physicians and hospitals and the vendors would have common cause to both negotiate and ultimately manage the cost of drugs. But in the DVP program, unlike the previous CAP proposal that CMS had, the vendors would have teeth. They could employ a formulary, much like Part D plans, and for really problematic areas, and this would be primarily the problem of negotiating for single source drugs with high launch prices, Congress would empower them in certain circumstances at a certain level of cost to collectively engage in mandatory binding arbitration with the manufacturers. And I can go into that a little bit more if you ask me. But the model was to use what's commonly called baseball arbitration, which means that the arbitrators cannot find a middle ground. They have to find for one party or the other, which creates a tremendous incentive for both parties to be careful about what their bid is, and in fact, in many cases, to avoid the process entirely. And in addition, and here comes the ASP add-on, the notion was that this would be a voluntary program, but over time, ASP, the 4.3% add-on, would gradually be reduced by Congress, creating an incentive for more and more providers to go in this direction. So what does that mean for the work that you're doing? If this were to take place and were to be effective, it would, as Don pointed out, lower the prices. So it doesn't directly affect waste, but waste as a percentage of the overall price would go down, primarily by using the formulary tools and the mandatory binding arbitration. But in addition, the notion here is to engage the physicians and the hospitals in having an incentive to think about and manage the cost of the drugs that they're providing. And so some of the ideas you've talked about before, such as dose rounding, batching patients, perhaps even the use of multi-dose vials in a safe manner, could be it could be incented essentially, because in this model, the providers would have reason to think carefully about how they're going about this and push back in some cases on the manufacturers. So that's the end of my prepared remarks. As I said, all these data ideas as well as MedPAC recommendations you can find here in the references, and they're all accessible online. With that, I'll stop.